Welcome to the podcast on complex care needs in older adults with dementia, background and general interventions. This podcast was created by Melissa Aslagi at the University of North Carolina, Wilmington, based on content authored by Dr. Lois Evans and Dr. Lenore Kurlowitz. It will be presented today in a dialogue with Dr. Bill Puentes. Dr. Puentes, would you like to introduce yourself?
My name is Bill Puentes. I have been a nurse for 26 years, and I am master's prepared as a clinical specialist in acute adult psychiatric mental health nursing. And I was one of the first people to go through the University of Pennsylvania's program with a subspecialty in geropsychiatric nursing. After that, I went on and earned a doctorate at Widener University in Chester, Pennsylvania. Then I went back to the University of Pennsylvania and I did a postdoc. And it was funded by the John A. Hartford Foundation. And during the 2 years that I was there, I spent a lot of time doing research with people that have early dementia. They were recently diagnosed or are only beginning the process of experiencing dementia, looking at self-management strategies that they can use in order to manage the anxiety and the depression that's associated with the early disease state. And I teach in a school called the University of Medicine and Dentistry of New Jersey School of Nursing. UMDNJ is the largest health sciences university in the United States, and on the campus that I work on, I'm also affiliated with a center. It's called the New Jersey Institute for Successful Aging, and we provide a whole host of disorders for older adults that are experiencing mental health issues or just difficulty with the transition into older adulthood.
So Dr. Puentes, based on your experience, maybe you can take us through a general introduction to different considerations that baccalaureate nursing students need to know when caring for patients with dementia. Some of the objectives that we'll cover today are to discuss the backgrounds and types of dementia, to recognize cardinal signs and symptoms of dementia versus benign memory loss, to review pathology and theories related to the development of dementia, to assess cognitive function and screening tools, to recognize stigmas associated with cognitive impairment testing and implications for conducting screening in older adults, as well as determine general interventions for caregivers and persons with dementia to promote maximum independence while maintaining functional status. Dr. Puentes?
Well, dementia actually is an umbrella term that represents a large group of disorders. So it's important that students understand that the term dementia itself isn't diagnostic, and it's important to be as specific as possible when you're trying to identify the pathology that an individual is experiencing. Some types of dementia, for instance, are the consequence of other disease processes like Lewy body disease or Parkinson's disease. And then there are different types of primary dementias like vascular dementia, and then the one that we're going to talk about today, which is Alzheimer's disease. And the reason that we're focusing on Alzheimer's disease is that it comprises the largest group of disorders in the dementia category, that the chances of developing dementia increase dramatically as an individual grows older, and by the time they reach 85, an individual has a 50% chance of developing Alzheimer's disease. It's the fifth leading cause of death in individuals 65 years of age and older, and it's the sixth leading cause of death in the United States. So there's some dramatic consequences that are associated with this illness, and it's important that students understand how to recognize it and how to help people find ways to manage it successfully. If you suspect that your patient may be experiencing cognitive impairment, the first thing that you'll probably identify is that there'll be some deficit in their memory. There'll be some significant short-term memory impairment. It's important, though, not to jump the gun and not rule out other causes, because in many cases there may be some other pathology going on, or the individual can be experiencing something called benign senescence, which is normal memory loss that's associated with aging. And what happens a lot of times, people might forget where they left their car keys one day or might have trouble remembering a name, and they panic because this is such a feared disease. And so it's important that you approach this in a very methodical and systematic way. And other signs, though, that people will begin to experience are things like impaired language ability. They'll have difficulty articulating words or completing sentences. Apraxia, which is the inability to perform complex motor activities, Or many people have the failure to recognize or use familiar objects or utensils. They're not sure what a toothbrush is for anymore, or what an eating utensil is for, and that's called agnosia. And then abulia, which is a disturbance in executive function, is particularly difficult for a lot of people to deal with. They have difficulty organizing their days, sequencing events, and engaging in problem-solving activities. As people begin to develop this constellation of symptoms, what begins to happen is that it has a very significant impact on their ability to live independently, both from the perspective of them being able to be safe, as well as to be able to complete the necessary activities of daily living just to maintain a state of health. In Alzheimer's disease, it's really a diagnosis of exclusion. The only way that we can definitely diagnose that an individual has Alzheimer's disease is on autopsy. And what we see is that on autopsy there are neurofibrillary tangles, and there are also high concentration of beta amyloid plaques. It's only recently that we're beginning to have an understanding of how these characteristics develop. For instance, it's been suggested that beta amyloid plaques actually play some sort of a protective function early in the disease process, and it's only when that function gets out of control that it completely disrupts the individual's brain activity and leads to the symptoms of Alzheimer's disease. Actually, it isn't the Alzheimer's disease that causes neurons to begin to die, but what's been suggested is that neurons die when they can't communicate with one another anymore, and they're no longer functioning. So it's that lack of function that leads to neuron death. So it's a fairly complicated pathological process that underlies the disease, and it's only recently that we've even developed the technology to be able to understand exactly what's happening to the individual. It's been suggested that genetic mutations or certain environmental exposures or abnormalities in brain proteins or neurotransmitters can all be contributing factors. But at this point, what most people suggest is that there are probably multiple etiologies that contribute to an individual to begin to express symptoms of the disease. It's important to make the distinction between Alzheimer's disease and something like vascular dementia, because the diseases progress in different ways, and the progressions help us to be able to determine the best types of interventions that we can provide. Alzheimer's disease, for instance, is a fairly sustained process. Once an individual begins to develop symptoms, there's a slide in their ability to function, and it's fairly consistent without any breaks in it. And the goal of treatment in Alzheimer's disease is to slow the progression of the illness. Think of a graph, and rather than have somebody decline at a 90-degree angle, what we want to do is we want to try and slow the decline so that the decline happens at maybe a 10 or a 15-degree angle. And by the time an individual reaches 85, 90 years old, slowing that decline can have a significant impact on their ability to continue to live a quality life. Vascular dementia, on the other hand, the decline is presented as in a stepwise fashion. So an individual will have a vascular incident, and there'll be a decline, but then there'll be a plateau, and they'll do okay for a while, and then there'll be another vascular incident, and then there's another decline. So it's a stepwise process, and our approach to managing the illnesses are a little bit different. The difficulty with Alzheimer's disease is that if it was just cognitive impairment, it might be easier to manage, but this actually is one of the most complex illness processes that you're going to be confronted with in your nursing career, because for the most part, people with cognitive impairment are going to be older adults. There are a few people who are diagnosed much earlier in life with Alzheimer's disease, but for the most part, they're rare, and most people are going to be older adults, usually beginning in their early 60s and beyond. And unfortunately, one of the problems with aging is that people also develop some other health problems too. And so what you're going to be doing is working with people who are beginning to present with a constellation of symptoms that interact with one another. And whenever you respond to one symptom, it may cause some unanticipated change in another realm of behavior. And it's important that you look at the whole picture. A lot of the medicines, for instance, that we use to treat Alzheimer's disease can cause an individual to develop urinary retention or swallowing difficulties. So if you're intervening with somebody who was incontinent, the medications that we use may change the whole treatment approach that you have to use. Cholinesterase inhibitors, which are the primary medications that we use, have effects on multiple systems in the body. And so students really need to look at the whole person. That's really the primary message, is that you need to look at the whole person. Dementia is not just a disorder of the mind, it's a disorder of the whole person. So it involves their mind and their body, and what a lot of people tend not to pay attention to is it involves their social system. It doesn't just affect the individual who's expressing the symptoms, but it affects the entire system that they exist within. Their family members, their friends, their housing situation, the community that they live in. So there are very complex issues that students have to learn to be able to deal with. One of the things that people tend to focus on, though, when you're working with people with dementia is that about 90% of people with Alzheimer's disease also have other neuropsychiatric symptoms. So we'll frequently see agitation, aggression, delusions, hallucinations, and something that's particularly distressing to a lot of people is repetitive vocalizations and wandering behavior. And it's been demonstrated that about 50% also experience significant depression, which is a very different kind of illness.
And actually, you'll see those symptoms across the spectrum of the disease, because most time when you think of an older adult with dementia, you think of these symptoms, but that's what the illness looks like. And there may be just varying degrees of each of those symptoms depending on what stage of the illness they're in.
And not just what stage of the illness they're in, but also what their unmet needs are. I recently worked with a woman who moved into a nursing home, and she stopped eating. And it was in part because their policy was that she would have to demonstrate that she was able to swallow, and so they provided her with pureed food, and she wouldn't eat it. But paradoxically, she spent the entire time talking about food. And so what we had to do was work with the nursing home staff and the family to try and understand what those repetitive vocalizations about food represented. And in this case, it seemed to represent the woman's need to look at mealtimes as a social experience. So she couldn't be alone in her room. She needed to socialize with other people. That was part of her nutritional needs. And the other was that food needed to be palatable. The woman had a history where she was a very good cook, and if the food didn't look nice and if it didn't taste good, she wasn't going to eat it. So pureed food simply wasn't doing it for her. But simply by making a few changes in her diet and by making sure that other people engaged her at a social level while she was eating, the repetitive vocalizations diminished, and then she made the transition into the nursing home. So it's important not to write off all of these behaviors as simply some behavioral problem that's associated with the disease process, but in many cases, these behaviors represent a need that the person doesn't have another way of expressing. So it's important to begin to investigate what some of these behaviors may represent, because it'll improve your ability to provide the care that they need. That is important for students not to. This is just like heart disease and hypertension and some respiratory diseases, that there are a lot of things that we can do to not necessarily stop the dementia process from happening, but to minimize its impact on the individual. And so this health promotion plays an important role when you're working with middle age and older adult populations. For instance, encouraging people to maintain physical activity. That's been demonstrated to have a positive impact on individuals later on by encouraging them to engage in mental stimulation activities like crossword puzzles, or even just maintaining a social interactions with the people around them, board games, ballroom dancing. All of these kind of things have a health promoting effect. And what we're trying to do by intervening early is helping individuals to develop something called cognitive reserve. So instead of starting at, say, 50% and then declining at 50%, if we can work with people to build that cognitive reserve and give them an extra 20 or 25%, they're starting higher up. So when you go back to that idea of a decline, if they're starting at 75 and then they're declining, you may be able to slow that decline, so by the time they reach the end stage of the illness, or by the time they reach the end of their life, which is a better way to say it, they probably have only declined to the point where they would have actually started the disease process if we hadn't done this health promotion approach. It's important that students understand that this is actually a very, very feared disease process, because people, basically what happens is an individual loses access to what we use to define ourselves as individuals, our memories, who we are as a person. And it's a very, very feared process. So what we tend to see early on is, especially in close relationships, is that there's a lot of compensatory behavior. So when somebody is forgetful, their spouse or their long-term partner may compensate in some way, like put up reminder notes or make sure that the car keys are always in the same place. And eventually, as the disease process begins to progress, people recognize that something is wrong, but denial plays a very large role in the early part of the illness, in large part because of the fear that's associated with this diagnosis. So many times what happens is that individuals don't come to the attention to healthcare providers until the process has really gone along pretty far, and it begins to interfere with their functional status or their social relationships. But even at that point, what we still see is that people do their best to hide the pathology because of a lot of the consequences that are associated with the diagnosis. For instance, in many states, once an individual experiences a diagnosis of Alzheimer's disease, they will lose their driving privileges, or they may lose the ability to control their own financial resources or where they live. And so there's people in interviews will be able to hold it all together, if you will, and it may not be as obvious that some cognitive impairment is present. The other thing that students need to consider is that think about how you feel when you sit down to take a test, the consequences that you associate with good or bad performance. And so there are a number of ways that we can evaluate people or screen people with early Alzheimer's disease. And most people are familiar with the mini-mental state exam, but there are other tools such as the modified mini-mental state exam or the mini-cog or the clock test. And you need to be careful when you approach people to do these screenings, because the feedback that I've gotten from people is they didn't perform as poorly as they may have because of their cognitive impairment, but the bigger issue was just being nervous about being tested. Mm-hmm. So test anxiety, especially when, and again, think about your own experiences taking tests in nursing school. I mean, if you don't do well on tests, it could affect your progression through your program or your ability to graduate or earn a nursing license. And older people are confronted with these same sort of consequences when they're in these situations. So the tests are excellent screening tools, and they're well validated. The mini-mental state exam, for instance, has been around since 1975, probably longer than many of the students listening to this tape have been alive. And there is a lot of evidence to support that it's a good tool. But it's important not to get so focused on asking the questions and giving the person a score that you don't pay attention to the context of how the evaluation is occurring. A lot of factors are going to affect the outcome of how an individual performs. There are a lot of things that you can do in order to set up a dynamic that will probably give you a more accurate reading of what the individual is experiencing. You need to have a quiet and private environment. You don't want to, for instance, be doing a mini-mental state on somebody at the nursing station when 30 people are running around. It's embarrassing, and it just makes the situation more challenging. You want to spend a few minutes establishing rapport with the person, getting them to relax and getting them to recognize that you're not here judging them or testing them. You're trying to find a way to help them. And the mini-mental state exam is really no different than taking their blood pressure or their temperature. It's another assessment tool that we have. And you need to be able to communicate to that person in some way. You need to attend to their display attending behavior. So your body language, for instance, plays a really important role. You need to look like you're interested in what they have to say and not just more interested in filling out a form. Actually, beforehand, if you can try and recognize what the 10 questions are in the mini mental state exam, the most successful evaluator is going to be the person who can actually put the tool aside and ask the questions in a more conversational way, because it demonstrates that you're really more interested in what the person has to say than filling out the form. And I encourage people to take their time and think about it. And older people are no less intellectually skilled than any other age group. It's just older people sometimes take a little bit longer to process their answer, in part because they're trying to be more careful in the information that they're providing, in part because they have a much greater store of information to draw from. So this isn't an assessment that you can hurry through. You need to take a reasonable amount of time in order to get the information that you need. The clock drawing is a really interesting test. Hopefully most of you learn to tell time on a clock with hands, and I've run into a lot of people, though, who haven't. They grew up learning to tell time on a digital clock. But what the clock game is that you ask the individual to draw a clock, and very similar to the mini mental state exam, where you're asking them to draw overlapping pentagons, someone with cognitive impairment, there's a visual spatial disturbance that will make it difficult for them to draw a circle. But once they're able to draw the circle, what you ask them to do is to write the numbers in the appropriate sequence and in the appropriate spots in the circle to represent the face of a clock. And then you ask them to actually identify a specific time, like 2 o'clock or 3 o'clock, and they need to put the hands in the right space. So it's really interesting because it's been demonstrated to be a really effective way to assess visual spatial skills and the ability to follow instructions and the executive planning. And if you go back to the Try This series from the Hartford Foundation that's available on their website, there's an excellent resource that explains the mini-cog, of which the clock drawing is one aspect. The other aspect is asking them to remember 3 things and then repeat them to you. And there's also a good resource there where there is a free video that you're able to view that will demonstrate how you go about using this assessment tool.
So one of the other things to consider is that when an older adult has dementia, that disease is going to impact their family. So what are some basic things that students need to know to help caregivers?
Both family and formal caregivers need some instructions on and coaching on some very specific tasks. For instance, in almost all healthcare settings, we're obsessed with making sure that people are bathed on a daily basis. But what you'll find with Alzheimer's disease is that some people exhibit symptoms where there's a great fear of water, and bathing them is a very traumatic experience. So you need to step back and think for yourself, why are we bathing them? Is it because there's some need that I have to make sure somebody gets a bath every day? Or do they actually need a bath? Do they need a bath, or could they have a sponge bath instead? Is there some way that you can approach the bathing process? And this is a particularly distressing issue for family members, because they're so used to certain hygiene habits, and when a person's hygiene habits begin to change, it's very distressing because it disrupts a long-established routine. So you need to talk to the family caregivers about how they may need to change the way that they approach the person and to reprioritize the things that are really the most important. And it's also a concept that extends to formal caregivers, because a lot of the care that's provided for these individuals occurs in long-term care settings, and we're beginning to see it in assisted living facilities. And even in acute care settings, we become so task-focused, and we prioritize the tasks according to our needs rather than the patient's needs. And care needs to be very, very individualized, because every person is so unique in the way that they exist. Well, the ultimate goal is you want to be able to try and structure the daily living to maximize whatever remaining abilities are there. So the disturbance in executive function, for instance, will impact the individual's ability to sequence bathing or sequence dressing or sequence eating. And so what you want to do is structure the environment and encourage informal caregivers to follow through on this and set up the person's clothes
In the order that
they would put them on, or make sure that only one dish at a time is presented to the individual at mealtime, or actually have all the utensils that they would need to shave or to shower, and encourage them to do as much as they can for themselves. Sometimes family caregivers just like nurses, feel the need to help a person do something to get it done. And what we need to do is let family members know that there is no time limit involved in a lot of these tasks, that it may take the individual 3 hours to get dressed, but they need to do it at their own pace. So the family member has to be comfortable stepping back and letting those kind of changes take place. There are a range of psychoeducational, supportive, and networking interventions that are effective in helping the individuals to relieve that sense of burden that they begin to experience, or to relieve a sense of depression, or just to increase their knowledge about what's happening to them. What people have told me, and people with Alzheimer's disease and their families have told me, is that in the beginning of the disease process, from the point where they begin to recognize that something is happening to them until about 12 to 18 months after a formal diagnosis, that there's a very, very high level of anxiety. And it's in large part because they don't know what's happening to them. They aren't able to make judgments about the future. And we've already talked about this idea that the illness is a staged illness, and we can anticipate that people will be going through very discrete phases. And so what happens during this first year, an important intervention is trying to provide the education that people need so that they can begin to anticipate some of the things that they're going to be experiencing. And it's important to recognize that if the individual doesn't die from some other type of illness, such as an infection or a respiratory or cardiac problem, that they ultimately will die from Alzheimer's disease. And so that planning for how an individual wants their care to occur towards the end of their life is an extremely important intervention that needs to begin to happen early in the disease process. I teach undergraduate gerontological nursing. It's a required course in the program that I teach, and I always begin the semester by asking how many people want to work with older adults, and inevitably 3 out of 50 hands go up, and everyone else wants to do emergency room nursing or critical care nursing or mother-child baby. And I just want to remind people that this is not a group of patients or a group of pathologies that you're going to be able to avoid working with, that no matter what setting you're working in, you're going to be working with older adults. They're the largest consumers of healthcare in the United States, and that cognitive disorders, and Alzheimer's disease is one example of that, are groups of disorders that we're going to be seeing more and more of because they're disorders of old age. And what we're seeing in our society is that people are beginning to live longer, and as a consequence of that, we're starting to see a lot more of these illnesses. So you critical care nurses are going to be working with people in the critical care unit who have the disorder. Emergency room nurses, they're going to be coming in because something happened in their disease management process, and you're going to have to be able to establish that rapport and minimize the catastrophic reactions that a lot of times you'll see in healthcare settings. So just to remind people that it's important that you understand what this disease process involves, because you're going to be exposed to it everywhere. I was talking to somebody who does mother-baby nursing, and she said that one of the conundrums that she faces is what happens when the demented grandmother comes into the nursery and wants to hold her grandchild for the first time. What do you do? Risk the child's safety in order to satisfy the emotional needs of that grandparent, or do you find some way to work with that situation so that everybody has a satisfying emotional experience? So there's just no way to avoid it.
Well, that concludes our time today. I would like to thank Dr. Bill Puentes for this great introductory discussion about dementia and some of the general interventions that we can use to help this patient population and their caregivers.